barulho da sala. Okay. So we can start now. We have the transmission for the YouTube, and we can start then the session of the defense session of the candidate Fernanda Yamamoto Ricardo da Silva. She is going to defend her PhD, which is an agreement between University of São Paulo and University of Groningen. Today is the second defense. We are going to have the defense here at University of São Paulo. And first, I would like to thank the committee members, starting with Professor Dr. Michiel Erasmus from the University of Groningen. Thank you, Michiel, for being here. I would like to thank also Professor Maria Cristina Velar from the Defesa, Federal University of São Paulo, for being here. Thank you, Professor Velar. And also Professor Paulo Cardoso, which is from here, from the University of São Paulo, Brazil. And I would like additionally to thank the presence of the other supervisor from the Netherlands, Professor Henry Leuvening. As a protocol, Fernanda will have 60 minutes to present her results, and then we are going to start and go to the questions and the evaluation. So Fernanda, you have the word now. You can present your results.
I will start the presentation. Let me share the screen first. Here. Okay, so I will begin. So my thesis is entitled Lung Inflammation After Brain Death, Sex Differences and Treatment Strategies. It was done under the supervision of Dr. Ana Cristina Braita Falopa and also Professor Dr. Henry Leuvening. So as explained before, this is a double PhD degree between the University of São Paulo in Brazil and also the University of Groningen in the Netherlands. We'll be presenting this thesis separated in chapters. The first one is in the introduction, in which here we can see the data from Europe regarding lung transplantation. We see here in the curve in light blue the total number of patients in the waiting list. And we can see that it doesn't quite match the bars that represent the lung transplants that were performed through the years. The same thing we can see if we look at the data from Brazil. Here we see the column in blue, that is the necessity for lung transplant. And it doesn't quite match the number of lungs that were actually used for transplantation. Not only that, we also know that when we compare the number of lungs that were transplanted with other organs, such as the kidney, we see that there is a great disparity because we have a lower number of lungs being transplanted. So if we have more studies that make us understand why this happens, and also that studies that could improve the quality of the lungs, we could hopefully increase the number of lung transplantations. So to understand that, we first need to know who is this donor that we are harvesting the lungs from. Here we have the data from Europe also. We can see that the majority of the graph here is in green, which would be the donation after brain death. So we should focus on patients that are in brain death, not only because they are the majority, but also in some countries such as Brazil, we know that we have only transplantation between leavings or from patients in brain death. So to first know this patient, we need to know what is brain death and what it causes. It happens when we have the increase of the intracranial pressure because mostly of cases of trauma or hemorrhage. And as a result of that, there will be no more blood flow coming into the central nervous system, responsible for controlling a series of body functions, such as breathing. So we know that there will be no more spontaneous breathing. And because of that, this patient will need to be under mechanical ventilation. will have no more control over the hormonal release and also over the vascular tunnels. So we will have, as a result, a hemodynamic instability. So to summarize, we understand that the brain death will generate a series of systemic alterations. So hormonal alterations, as I said before, alterations in the coagulation process. There will be the development of an inflammatory response also, and what we call an autonomic storm, which is the release of catecholamines in a great quantity into the system. So as a result, we will have, as I said before, a hemodynamic instability. And all those factors will help to alterate the endothelium. And because of that, we will know that there will be alterations in the microvascular circulation. We could have tissue apoptosis and also necrosis, but also what we call a remote inflammation. So we will have inflammation not only in the brain where it all started, but also in remote organs such as the lung. And if those alterations are not controlled or treated, we could have a morphofunction impairment. So the lung, for instance, could be not in a viable condition for transplantation anymore. We also need to highlight for this thesis specifically that many hormones, not only insulin, cortisol, and thyroid hormones that we have a lot of studies in the literature, but also the sex hormones are very important. And the release of those hormones will be altered because we know that there will be a failure of the hypothalamus pituitary and pituitary. We have some studies that have taken into account the sex differences in the clinic. So for instance, this study that I'm showing here that was done in the International Society of Heart and Lung Transplantation Registry, they have used the bias of the sex differences to compare the success from donors and recipients of the different sexes. And what they have found is that there is a worse combination for that. So they saw that the female donors with a male recipient was the worst combination for lung transplantation. And what we know from what there is already in the literature is that the sex differences actually modulate differently in males and females the immune system. There is a series of factors such as the environment, but also differences in the anatomy and also genetics. And most importantly for this study, there is sex hormonal differences between males and females. Especially progesterone and estradiol, the female sex hormones, we know that those actually have a series of studies showing that they actually modulate the immune system. There are not only clinical data, but also experimental data showing that in cases of trauma, shock, and sepsis, the concentration of estradiol is correlated to the development of lung inflammation. So here in the graph, we can see scheme, but when we have a greater concentration of estradiol, we actually have a protection of the lung in those cases of trauma. But in comparison, if we have females that have lower concentrations of these hormones, or if we take into account males which already have physiological lower concentrations of estradiol, they have more harmful actions into the lung. So taking into account all this data that we know, we decided to aim the thesis into investigating how the different sexes of the donor, so the patient in brain death, could alter the inflammation and the quality of the lung and therefore alter the transplant success. We also decided to take into account these differences, especially the presence of the female sex hormones, to understand and try to investigate how it could be used to treat and improve the quality of the lung. So here in chapter 2, we start the first work of this thesis. It is entitled Sex Differences in the Coagulation Process and Microvascular Perfusion Induced by Brain Death in Rats. For this study, we used females and male Lister rats. They were anesthetized with isoflurane in a closed chamber and maintained via oral tracheal intubation. They were kept through the experiment under ventilation. We performed the surgery and started the brain death with a fast induction, in which we insert a catheter balloon inside the intracranial space and then insufflate it in a rapid manner. And with that, we see that the mean arterial pressure will present a hypertensive peak. And with that, we could confirm brain death. Once it was confirmed, we started to count the time of the experiment, and we maintained those animals for 3 hours. During that period, we had the carotid artery catheterized to assess the mean arterial pressure and also the jugular vein for volume replacement. So in total, we had 4 groups, the males and females submitted to brain death, and as control, males and female group animals, which didn't have the surgery or the brain death. The first main data from this work was regarding the perfused vessels. We see that there is a greater percentage of that in the females in brain death compared to males in brain death. And also they presented a greater count of leukocytes in the microcirculation. At the same time, we also saw that in the blood, the females in brain death presented a greater count of platelets. And that correlates to the data regarding platelet aggregation, in which we see that there is a shift in the pattern. So if we first look at the control groups, we see that we have actually a greater aggregation of the platelets in the females when we don't have the brain death. But in the brain death group, this pattern is shift, and then the males start to present a greater aggregation, as we can see in the figure in the bottom. So to try to understand why this would happen, we decided to assess the release of nitric oxide, because we know that it controls platelet aggregation and also activation, but it also modulates the vascular tonus by causing vasodilatation in the vessels. So with that, we could maybe understand why there is difference in males and females in the perfusion and the coagulation process. There is also data from literature showing that estradiol actually controls the expression of nitric oxide. So it could be one of the reasons why we see that pattern in females. And what we actually saw was that the females in brain death compared to the males in brain death, they presented a greater concentration in the serum of nitrates and nitrates, which are the soluble forms of nitric oxide. So as a whole, what we understand is that males and females present different alterations in the coagulation and also the perfusion. And that actually correlates to what we see from other studies showing that the females, while maintaining the perfusion and having a lower platelet aggregation, they also present a greater lung inflammation, in which we see a greater leukocyte infiltrate and also greater release of inflammatory mediators. And although we see an inflammatory process in the males, they don't present the same scale of the response. So to try to understand why we see this greater inflammation in the females, we decided to investigate if the female sex hormones, which we already know that modulates the immune system response, we decided to see if reducing the female sex hormones by doing ovarectomy, we could modulate the development of the lung inflammation caused by brain death. And that is shown in chapter 3, the influence of female sex hormones on lung inflammation after brain death, an experimental study. For that study, we used female rats. They were submitted to surgery and brain death, as explained before. And we had the females either ovarectomized 10 days before the brain death induction or not. So we had females that had the concentrations of female sex hormones in a greater concentration, or females that were accustomed to lower concentrations of the estradiol and progesterone before the induction of brain death. We maintained those animals for 6 hours, so it's a bit longer the time compared to the other work. And we had as total 4 groups: females submitted to brain death with or without the ovarectomy, and also as control groups, females that were ovarectomized or not. And again, they were not submitted to surgery or the brain death. The first result from this work is the concentration in the serum of female sex hormone and corticosterone. We first saw that brain death does indeed reduce acutely the concentration of the female sex hormones, but also the corticosterone levels. And that is what we would expect, as we know that the brain death actually causes a failure of the hypothalamus and pituitary. We also see that in the control groups, when we compare the ovarectomized animals, we see that those present lower concentrations of the female sex hormones, but also lower concentrations of corticosterone. And to understand what was happening with the inflammation, the first parameter that I'm showing here is the relative gene expression of INOS. Here in the graph, we can only see the brain death groups, and we can see that clearly the females that were not ovarectomized, they present a greater gene expression compared to the ovarectomized ones. So we start to see that the presence of the female sex hormones before the brain death and afterwards the reduction of those would start to influence the inflammation process. We also decided to analyze the concentration of inflammatory mediators in the lung, and for that we used what we call explant, in which we take fragments of the lung, we put it in a culture medium, and we analyze 24 hours this medium for the release of those mediators. And what we saw is that many of those inflammatory mediators were increased in a greater quantity in the non-ovarectomized group and in brain death compared to the ovarectomized group. We also analyzed for leukocyte mobilization, and although we didn't see a difference in the white blood cell count, we do see that we have a greater leukocyte count in the bronchoalveolar lavage and also in the lung tissue of the females that were not ovarectomized but submitted to brain death. So as a whole, what we can take from this study is that the females that had an acute reduction of the female sex hormones caused by brain death develop a greater inflammatory response. So we can clearly see that the development of a lung inflammation is correlated to the female sex hormones concentration. And as expected, we see that the ovarectomized females produce an inflammatory response, but that is in a lower scale, and that would be explained because we see that those females have already been accustomed to lower concentrations of the female sex hormones. So knowing already that the female sex hormones are important and that estradiol specifically, there is a lot of literature showing that it could be a protective agent for the lung in cases of trauma, we decided to answer 2 questions. The first, if the female sex hormones, specifically the estradiol, would be responsible for the lung inflammation caused by brain death, but also if the estradiol treatment would be capable of controlling the inflammation caused by brain death. For that, we used 2 different treatments, one starting right after the confirmation of brain death, and another one that started 3 hours after the brain death was confirmed. So we had a 3 hours period for the lung inflammation to start. And that is shown on chapter 4. and it is entitled 17 beta estradiol treatment protects lungs against brain death effects in female rat donor. We used it again, female rats. They were submitted to surgery and brain death as described before. We had first the brain death group, which was very similar, the same as the work before. We also had two different treatments as described. One that was during the whole period of the experiment, so during 6 hours, and also one treatment during the 3 final hours of the experiment. As control, we used the falsely operated animals. We call them sham, and in those we did the surgery, but not the brain death induction. The first main result that we have is regarding the estradiol concentrations in the serum, and we can see from the data in the table that the estradiol treatment was effective in increasing the concentration of these hormones when we compare to the brain death group. We first analyzed for lung inflammation the mobilization of leukocytes. We analyzed in the cell count in the bronchoalveolar lavage, and also the lung infiltrate in an in vivo manner using the intravital microscopy technique. And what we see is that both estradiol treatments were able to reduce the bronchoalveolar lavage cell count, but also that specifically the 3 hours treatment with estradiol was able to reduce the leukocytes when we see in an in vivo manner. To also complement this, we did a lung histopathology analysis, and we see that both treatments reduced the leukocyte infiltrate in the lung tissue. And more specifically, the 3 hours treatment also reduced edema and hemorrhage. To analyze the chemokines released from the lung, we did the same excellent method in which I explained in the work before, and we can see that both estradiol treatments were able to reduce the release of those chemokines. We also analyzed adhesive molecules, ICAN1 and VCAN1, and we see that again, the 3 hours treatment was able to reduce the protein expression in the lung tissue of this. Here I want to highlight the ICAN1 is very important because we know that it is related to the adhesion and transmigration of leukocytes, not only through the endothelium of the vessels, but also into the alveolar space. So it could explain the data that we see on leukocyte mobilization. We also decided to analyze gene expression and also the protein expression in the lungs of TNF alpha and IL-1. What we saw is that the estradiol treatments, again, they were able to reduce the release of these cytokines. We also analyzed the gene expression of metalloproteinase 9, and we see here that this time the 6 hours treatment, so the E2T0 group was able to reduce the gene expression of this enzyme. But more importantly, both estradiol treatments were able to reduce the activity of metalloproteinases, so they would not be degrading the extracellular matrix. We also analyzed parameters regarding permeability in the lungs, and here we can see that the brain death was increased the sterilization of Evans blue dye, and at the same time increased the presence of nitric oxide in the lung tissue. At the same time, we also see that the protein expression of the enzymes that produce nitric oxide was altered. So we see that iNOS here is increased in the lung tissue, and on the other hand, the endothelial nitric oxide synthase is reduced. And that could show how we see a greater inflammatory response in the lungs. And what we see is that this estradiol treatment, although it regulated other inflammatory response in the lung, it was not able to control the increase of the permeability. So as a whole, what we see is that the brain death produces a lot of lung inflammation, and also that both estradiol treatments were able to reduce this lung inflammation, especially in the leukocyte mobilization and the release of inflammatory mediators, with special attention to the 3 hours group that was able to reduce in a greater scale this lung inflammation. To continue this analysis, we have chapter 5, which is called long-term lung inflammation is reduced by estradiol treatment in brain-dead female rats. For this study, we used the same experimental design as described before, so we can see that we have the same groups. And for this study, the first main result I want to show is regarding the complement system activity, and we analyze specifically the C3 component. We see that in the serum, we have a reduction of this in the 6-hour treatment, so the E2T0 group. And we also see that the same group was able to reduce the expression of C3 in the lung tissue. And also, on the other hand, the 3 hours treatment, so E2T3 was able to reduce the gene expression of C3. We also analyzed caspase-3, which is a pro-apoptotic protein in the lung tissue. And although we didn't see a difference in the gene expression caused by the estradiol treatment, we see that the 3 hours treatment was able to reduce the expression of this marker. We also try to analyze what it would the estradiol treatment would influence in the future. For that, we did a real-time PCR analysis and also the explant culture that I explained before. So what would be released 24 hours after the experiment ended. And we see that in TNF alpha and IL-1 beta that both estradiol treatments were able to reduce the expression of these chemokines. We also analyze gene expression and the lung culture release of IL-6. Although we didn't see any alterations with this estradiol treatment, we do see that IL-10, which is the anti-apoptotic, anti-inflammatory cytokine, it was increased by the 3 hours treatment. So as a whole, what we understand again is that brain death produces an inflammatory response in the lung, and we see that the estradiol treatment was able to reduce the inflammation in the lung, not only from a short-term aspect, but also in long-term analysis. So things that would show what would happen a long time after the experiment ended. So as a whole, we, as I said before, we understand that estradiol was able to protect the lung in a short and a long-term manner, and that could possibly influence the outcome in the transplant in the future. So knowing that there is differences of females and males are important, so we could understand how it affects lung transplantation and therefore the response in the recipient. A new methodology that it has been very much used in the clinic and also studied in the experimental studies is the ex vivo lung perfusion. This setting is very important because we can actually preserve better the lungs before transplantation and actually evaluate it and maybe treat if needed before transplantation. So it would be one technique in which we could have a better understanding of the organ and also evaluate it. In chapter 6, we used this methodology to make a comparison of males and females and analyze the inflammatory response in a brain death model followed by the ex vivo lung perfusion. So for this study, we used males and female Easter rats. We submitted them to the surgery very much like the previous work, but for this one, we used a brain death in a slow induction, in which the catheter inserted in the intracranial space was insufflated in a slower manner. So usually it takes around 30 minutes for the brain death to be confirmed, differently from the fast induction. We maintained the animals in ventilation for 4 hours, did the lung procurement. This lung was placed in cold ischemia for 1 hour, and then placed in the ex vivo perfusion machine for 4 hours. And after that, we did the lung analysis. So we had 4 groups in total, the lungs from males and females in brain death, and also the sham groups, which were males and female animals that were submitted to the surgery, but not to brain death. They were kept under ventilation for 30 minutes this time, and then placed in cold ischemia and ex vivo perfusion, the same as the other groups. The first main data from this study is regarding leukocyte infiltrate in the lung tissue. We see that the female brain death animals, they present a greater leukocyte infiltrate compared to the males in brain death. And we also see that this group, the females in brain death, also presented a lower hemorrhage compared to the males. We also did immunohistochemistry analysis for the MPO, which is enzyme that we find in the granules of the neutrophils. And this was found to be in a higher expression in the lung tissue of the females in brain death. We also analyzed IL-1 in serum and gene expression, and this parameter was increased in the females in brain death, again, compared to the males. And also what we observed is that the females in brain death, compared to their controls, presented a greater release in the serum of IL-1 beta, but also in the perfusate, so after the ex vivo perfusion. So as a whole, what we understand is that brain death produces a lung inflammation in both sexes. But what we see is that the females continue to present a greater lung inflammation compared to the males after the ex vivo perfusion. So in chapter 7, we have the summary. What we can understand as a whole from this thesis is that males and females present a distinct response to brain death, in which we see a dimorphism in the microvascular perfusion and also the coagulation process. We see that the females present a greater lung inflammation at the same time that they have a preservation of the microcirculation. And in the males, we see, although we see a lung inflammation, it is lower compared to the females. And at the same time, we see a compromise of the microcirculation. We know that the female sex hormone, especially this estradiol, is associated with the development of lung inflammation caused by brain death in females. We also know that the estradiol treatment is able to reduce the lung inflammation, not only in a short but a long term, and they do that by controlling the release of inflammatory mediators, the expression of adhesion molecules, but also the mobilization of leukocytes. And finally, we also see that the sexual dimorphism was observed also in a slow induction of brain death model, followed by ex vivo lung perfusion. So in conclusion, what we can take from this work is that we should consider sex and also age of the donors as an important criteria for lung transplantation, where we know that the females should be considered of a greater risk when they are in premenopause. So when they have greater concentrations of estradiol and progesterone. And finally, we also know that we can understand from this work that the female sex hormone, especially the estradiol, they could be considered as a possible therapy in the future for lung grafts, either in the donor or in the ex vivo lung perfusions. And that's what I had to present. Thank you very much.
Yes. Okay. Yes, we are back now. And now we are having the second phase of the session. We are having the chance for the committee to argue with the candidate. So I would like to ask Professor Michio Erasmus to start. He's going to be the first one to have the chance to ask questions for the candidate. Normally we have 20 minutes for the one who asks and 20 minutes for the answers. But you can opt to do like a dialogue. So you have 40 minutes on total to talk to Fernanda and ask your questions. Okay, thank you again for your presence, and the microphone is yours.
Thank you very much. Fernanda, thank you very much for this presentation and also of submitting your nice booklet. I enjoyed reading it because it's a thorough investigation and totally in the field I'm very interested in, but with a total new perspective. So it's very interesting to go into that. And I want also congratulate your whole team with this thesis. And what I forgot to say when we were in Groningen, I also wanted to congratulate the whole team in Groningen who set up this ex vivo lung perfusion system together with you, because I know it's very difficult in rats and you performed a nice series of experiments on that. So congratulations. But now we have to do some questioning. So during the thesis, I think it's central that there is a difference in male and female. I was there in Sao Paulo and saw the experiments on male and female rats with the perfusion of the mesenteric vessels, and saw the great difference of reaction. And it was all about the vessels. There was something going on in these vessels, and it was not clear whether it was the coagulation or the attraction of leukocytes or the platelets. It was not totally clear. And I think, and that was also already questioned during your previous defense, is that you nicely showed that the females reacted totally different and were more inflamed, had higher leukocytes, and especially also higher inos. The only question that was asked, and it was also a question I had, was that in the first experiment you did, that's chapter 3, and especially because I'm also looking at this factor, and that's the VCAM. We didn't understand that in chapter 3, when you look, let's see, it's page 50, figure 4, and then part B. There you see, when you look at the female that had not an ovariectomy, that the controls have a higher VCAM score than the brain death. And I don't think that you expected that. Can you comment on that?
Yes. Okay. I think you can this time explain a bit better, but first let me thank you for your participation in this thesis. It's a pleasure to have you here and hear your comments. I'm sure it will be very interesting. So to the question, so I guess I responded very briefly at that time. I will extrapolate it a bit more. So the first thing that I explained on that time was that we have, so the first thing that we see is that in the overoptimized group in the chapter 3, we see that we have also lower expression of VCAM when we do the brain death. And also what we were probably really need to look at is the not overoptimized group, because it would be more similar to what we see in the figure D of chapter 4. So we need to remember that those are a bit different and the scale is not the same. So we see in the chapter 3 what is control animal. So it was not submitted to the surgery. It's not the same as the sham in the other one, and this animal was under ventilation. So we probably had the development of an inflammatory process for that one. And,
yeah, but if I may interrupt, that's exactly my point. I think these controls are even more non-inflamed controls than the sham in paragraph 4. So you would expect a very low VCAM in this controls
yes.
of this series. And when you then inflict injury, the normal reaction is that VCAM goes up. And now you inflict an injury, brain death, and the VCAM goes down. So I'm not asking you exactly how you explain this, but do you think it's strange or not?
Yeah, it was actually a bit confusing when it was first pointed out, but I actually had a bit more time to study a bit about the subject. And what we need to understand is that usually when we try to think of inflammation and protein, we are talking and thinking about the male. And what I have seen from studies, not in the brain death that much, but if you take into account studies in ischemia reperfusion in females, I know from data from previous works from my other laboratory that in females, when we have when you have the estradiol, possibly progesterone maybe also, but more estradiol, we know that it modulates the expression of VCAM. So this could be one of the reasons why we see a difference in the expression in the brain death group, in the naive or sham, why we see this different pattern. So even though we expect normally that VCAM would be the one increasing, estradiol could be one of the reasons why we have a different modulation from the expected.
Okay, so you think it's only the difference in groups and not
hypothesis, but we can know for sure if we don't investigate more truly with more more specific study.
Okay, thank you. Then I would go on, as you nicely showed in your introduction, that also even already for years it's known that the lung transplant results in clinical lung transplant results are influenced by sex. So, and especially this nice overview you showed from the Toronto group is that female and male is the worst combination. And I think that's supported by your work. You have some explanation for that now, that maybe these females' lungs are more inflamed. Now, it's also for importance for the female lungs that the estradiol is present. So, and in the last slide, you showed that you suspect that estradiol treatment would be worthwhile, and you showed it already, during brain death, during ex vivo lung perfusion, but you didn't say anything about the acceptor. So you didn't talk about maybe treating the acceptor with estradiol.
Receptor, oh, yes.
My question is, especially when we see in the same publication of Toronto or from Shevchevsky that female to male were the best combination. Female to male was worse, but female to female was the best combination in clinical lung transplantation.
Okay.
So could you hypothesize whether it would be beneficial to treat males with estradiol during transplantation?
So you mean treat males, the donors or
no,
the
recipient? The recipient male,
the donor.
the recipient male with estradiol when he receives a female lung.
If I had to hypothesize about that, I would probably say that it would benefit males because we know from other works in different models that estradiol has anti-inflammatory properties when we have, for instance, ischemia with perfusion. So if we do the transplant, and even more if we have a female organ donated to this male recipient, this organ will be more, present more protective actions because it has a lot more of the estradiol receptors. So even not only from female donors, but also from males, I would probably say that it would have benefits. But it needs to be a treatment in which we have so it would be a bolus, so you need to do acute treatment. So we could have the beneficial effects of the estradiol in the males.
Okay, and these estradiol receptors, where are they located?
You mean in the tissues or the cell?
Tell me.
Okay, so there are a lot of estradiol receptors in the whole body. They are differently expressed. So we have 3 kinds of receptor in total. We have the one coupled with the G protein, the G pair, and is located in the membrane. And we see in a lot of organs. And we also have 2 that we most commonly call nuclear receptors, but there are also studies showing that it could be actually present also in the membrane. So we can't really call them anymore nuclear receptors. And the alpha and beta one, these 2 kinds, they are differently expressed depending on the organs. So for instance, the lung, for example, we know that it has a lot more estradiol receptor of the beta type. And we know from other works that this one, when we do agonist, especially for this kind of receptor, it presents more protection to the lung. I think that's it. But I can talk about the other organs, but I think
Yeah,
I have.
and it's especially so on the cells of the lung. When you transplant the female lung, you also transplant a lot of her leukocytes. You showed
Yes.
that the leukocyte infiltration in these female lungs is higher. Do
Yes.
these leukocytes also have estradiol receptors?
Yes, they do have receptors, and we know from a lot of literature that this estradiol can not only modulate the white blood cells, but also platelets. So it could be regulating macrophages, neutrophils, platelets, as I said before, and a lot of natural killer cells. There is a lot of work in the specific kinds of human cells.
So normally, I did yesterday a very difficult lung transplantation. It was a retransplantation. And we always see, and we always do, just before reperfusion, we give high doses of corticosteroids, just before the reperfusion of the first lung, and then also when we transplant the second lung. But so maybe in the future we have to add estradiol when that's a female lung. Is that a possibility to do research? Because we do research on the first, after 10 minutes, we take some blood from the pulmonary vein to see how this lung reacts. And I'm really curious if this would help female lungs to give some extra estradiol at that phase, at that late phase.
Yes, I do believe it would probably help. Not only estradiol, but actually if we have corticosteroid, it would probably also help, because we know that they have actually a convergence in the actions. So in the, not only for the gene expression, but also in the non-genomical pathway of the action of estradiol and corticosterone, they are very much acting through the same pathway. And actually we are developing in our laboratory combined work of treatment using corticoids and also estradiol, as we know from works from Judith, from Bruni, and also a lot of other works. We already know that corticoids, they are very good for treating inflammation, and there is literature showing that estradiol is good. So possibly we could have a better treatment when we have both of them working together. Yes,
thank you. Okay, then I want to go to the chapter on the EVLP. Can you tell me something about the setup you chose? Because the setup was with the setup of the ex vivo lung perfusion system.
Yes.
There was a leukocyte filter built in, I see in the scheme.
Yes.
And did you, during the 4 hours you perfused the lungs, did you anything else to keep the solution fresh?
No, it was recirculating and the leukocyte filter stayed there. So we didn't change the leukocyte filter, and the perfusate was just
recirculating.
The only thing that we did was deoxygenated when we were analyzing the gases in the perfusate, and also taking samples.
Did you have to correct for pH or something?
We corrected for the pH.
That was only once or continuously?
Continuously, but as we can see, what we did was try to regulate it with the with the carbogen. because if we use, but as we can see from the data here, we actually had a drop of the pH, so it wasn't that much regulated. You can see we tried, but we didn't see. But we also had we replaced it also the glucose.
Yeah,
that was what I wanted to say.
yeah. You added glucose during the experiment. Yes, yes. Thank you. Now, of course, I found this a very interesting chapter because you now really compare the male and female on lung tissue, and you showed again real differences after the brain death, and then you put these lungs, those different lungs, the lungs with more infiltration, the female lungs on the ex vivo perfusion system, and the male lungs with a little less inflammation on the system. What was the expectation the ex vivo lung perfusion would do to these lungs? Before you started the experiment, what was the hypothesis what the ex vivo lung perfusion would do? Or didn't you expect anything? Why did you do the ex vivo lung perfusion?
Yes, so actually, my personal expectation was that it would be very good because from what we hear about it before I started really studying it and understanding the whole setup and what it does, actually, I had a very good impression and thought it would be a kind of a magical solution. But what I learned, and also what Henry explained to me, is that it actually is just a setting in which we can do more things with the lung and have it in a more close to physiological, but not exactly physiological condition. So it would probably be better than a cold ischemia. And I think it would be good for the lung, but as we can see, it was different from my first expectation. And as we were analyzing, we actually, when I was doing the experiment, I actually felt that the female lungs were in a, just like the look of the lung, you could say, I felt that they were struggling a bit more. So I would probably think that they would be more inflamed while I was doing the experiments. And actually this was confirmed when we did all the analysis.
Yes, yes, because that's the true story about ex vivo lung perfusion. Exactly what you showed is that when a lung is inflamed, you do not do much during ex vivo lung perfusion, unless, I think, when you add a treatment. You have specifically treat this inflammation. On the contrary, there are some studies that show that every lung that was on ex vivo lung perfusion shows after transplantation, when they take biopsies like a few days after lung transplantation in the clinic. It's a famous paper where Stickstein also was involved, that they showed less leukocyte infiltration in these lungs. So normally preserved lungs without ex vivo lung perfusion and ex vivo perfused lungs were compared after lung transplantation, and they had less leukocyte infiltration. And they say, yeah, during ex vivo lung perfusion, the leukocytes are flushed out, but that you cannot confirm with your ex vivo lung perfusion setup in rats.
Yeah, I have read, I don't think I have read the whole literature on ex vivo lung perfusion, but from what I have seen, most of those studies that have actually seen leukocyte mobilization, they don't really, either they don't specify which is the donor that much, so we don't know if it is a brain death, if it is a cardiac arrest. And mostly in the experimental studies, they just take the organ from the donor, put it in a code ischemia, and then assessing the ex vivo machine. So it doesn't really show the same thing that we did. So we had previous to the cold ischemia inflammatory process, and all the leukocytes could really infiltrate into this tissue, and that wouldn't possibly happen when you just take the lung and put it in a cold ischemia, because it is not already in the body anymore, and we couldn't have the infiltrate. So I think that this is a more complete study that could really relate more to what we see in the clinic for the brain death individuals.
Yeah. Yes, thank you. Thank you. Let's see if I had more questions. Let's see. No, I think I had all my questions. So thank you for answering it. And I'm happy to hear your following defense for the other guests. Thank you very much.
Thank you for being here.
So thank you, Michiel, for your questions. Thank you for being here again. And then we are going to move on to Professor Maria Cristina Velar. That's going to make then her questions. Thank you for your presence. And you can do it in Portuguese if it's your wish to do it. We have this possibility, as we have the two the people from abroad and people from Brazil. We can do it in Portuguese if you want to. It's not a problem. It's your option to decide which language you want to use. Okay? Thank you.
Thank you, and thank you. Good morning, everybody. So, Fernanda, either way, what are you more comfortable, English or Portuguese, or maybe we can have a mixture if that is a question that we can maybe explore more in Portuguese. So let's keep in English for now, so the other colleagues can follow our thoughts. Thank you so much for your first questions, the round of questions, Professor, because it was very nice to hear all your points. And Fernanda, thank you so much for this invitation. I think it has been very a pleasure to see, you know, how much you have developed your work. Oh, can you hear us? Can you hear me? Oh, okay.
Okay. We have a connection problem. We did not listen to anything because we are not here. So now we are back. Sorry, could you start again, please?
Oh, okay. Okay, Fernanda. So, so thank you so much for this opportunity. It has been very nice, you know, to see how much you have progressed in all these years, because I remember years ago, I was with you discussing, you know, the preliminary ideas that you had for this project. So it's very nice to see how much you have worked, and so congratulations for your thesis and also your advisors, both at USP and in Groningen. So all the team members, so it's very nice to see, and I'm very happy to participate here with you again today. And so I'll keep in English, and if you want at any point to, you know, change to Portuguese, let me know. But maybe if we keep in English, then we give a chance for the colleagues in the Netherlands to follow our discussion. So Fernanda, I was actually very, I said before that I was pleased to see the first round of questions that you had, because it helped me to move actually to a couple of concepts that I think it is important to better understand, or actually to, how can I say, to help you, you know, from now on, because I see in the last chapter that you do point out, you know, perspectives to your work. And I think part of that involves the sex hormones and also corticosterone. So the part that I would like to focus more with you is exactly about the physiology behind these hormones a little bit more. And because I see that with your publications, you are very effective to show how males and females are behaving differently when you have the brain death. And then like we are seeing now in the first round of questions, how this is so important to consider when you have the donor, the recipient, and you are considering this important clinical situation that is lung transplantation. And one aspect that I would like to first focus with you is exactly the sex differences. And I didn't have a chance to ask you this last week because we only had like 5-6 minutes. But because I am in the endocrine pharmacology, I would like just to go to this very basic concept when you say female hormones. So what do you understand with female hormones? Because, when you are describing in your papers, you are focusing on estradiol, and progesterone. Are those the only female hormones? I would associate in that question. So if we are comparing females and males, and I know you understand really well, the sources and how estradiol is synthesized and secreted in the female, but what about the male? So because you say estradiol, estrogen is actually that important. So what is your concept of female and male sex hormones? And how is, what is important when you are considering estradiol in the male? So how estradiol is produced in the male? Can you, it's a conversation. So I can guide you to one important thing that I think we can consider here.
Okay, so firstly, I would like to thank you for your presence. It's a delight to have you here. As you said, the work has grown very much from the preliminary data, and actually I think you have contributed a lot to the studies that we were doing at the time. And I think we have just expanded on what you have actually pointed out to us. So it's very much a pleasure. So through to the questions, the first one was the female sex hormones. So I believe probably generalizing, as I'm saying, progesterone and estradiol. I think I have put in the text, probably a bit nervous and I'm not finding it, but we know that there are other female sex hormones. We just usually say progesterone and estradiol as those are in higher concentrations. I probably can't remember right now, but I know that there is trio and another one that I'm really forgetting right now. But we know that there are other female sex hormones, and they are important, but probably mostly we focus on the 17-beta estradiol specifically because we know that this one is presented in a higher concentrations, and it would probably be the one really changing and modulating the immune response. And I think you said something else, but on in regards to estradiol actions in the males, I think this is actually important because we are in this thesis basically focusing on the females, but males are also very much important because we can't really choose in the clinic if we are having a female or a male. I guess probably what my work is showing is not that you should be picky, but that we could possibly have a more strict, more specific strategy when we are thinking about the donor. So in males specifically, we know that estradiol does have a role in the inflammatory response, although they present a lower physiological concentrations of the female sex hormones, not only estradiol but also progesterone. We know from all the cascade that we have for the production of these hormones, they have a common
Substrate.
stream. Yes, I was forgetting the word. So they have a common stream, and they have enzymes that produce this estradiol in the males. And there are some works showing that indeed not only females produce estradiol when they are under stress and inflammatory response, but also the males. So we could possibly say that estradiol and also corticosterone, because we know that there is a lot of work showing that it is important in both sexes, but also estradiol could be one of the hormones regulating the inflammation. I think from this work specifically that I'm talking about, they have shown that estradiol would be related to the cortisol peak that we have in not only in females but also in males. So the release of corticosterone would be related to the release of estradiol. So that would probably begin to show why estradiol would be important for males. Not only that, there is a lot of works that are done with estradiol treatment in other sort of trauma models. So not brain death I'm talking about, but when we are talking about shock or sepsis and any sort of trauma model, there is studies showing that estradiol treatment and even an agonist for the receptor beta of estradiol in the lung, they could actually reduce the inflammation. So in this regard, they are mostly focusing on estradiol, but probably the corticosterone levels are also influencing it. So it's probably all those together. And I think you talked about in the previous defense also about the what we call the male sex hormone, so testosterone. And for that matter, I think probably testosterone would be, I think in the graph that I showed in my presentation, it shows that when you have greater concentrations of testosterone, it would relate to great inflammatory response. So we could be having a regulation of all those hormones in the male, and that could be controlling the inflammatory process.
Okay, Fernanda, thank you for that response. So I see you have a very good idea about the hormones and everything that can be, affected by these hormones. But if I can suggest you now to think about the first step, so that I think it's important for you to consider from now on. So either in males or females, the first step that you need to have estradiol in the system is actually to have testosterone and aromatase, right? So if you go back to your steroid, that table that usually we have in the physiology books or in the pharmacology books, and you consider how steroids are produced in our body. So you can see there that the point that you need is testosterone gets into the cell where there is aromatase, and then that's how you produce estradiol in the body of a female or a male. And I think when you have your first chapter here, you are very effective, in directing the literature and the data that we need to understand your own data is fine. But because you are teasing us now to think the next step and how things are really happening in the male and the female, in terms of physiology and also the pathophysiology, because you are considering lungs after brain death, and then lungs that you want to take to another, the body of another person, right? That you also needed to consider how this person is, especially in terms of sex hormones, that is so important for the health of either males and females. So let's go to this first point. So, and I think that this is something that I was missing in all your chapters, is to make clear that either in males or females, what you have now is you have sex hormones, and in the female, estradiol and progesterone. Well, let's focus on estradiol now. It is in higher abundance, but you also have estradiol in the male, right? And the sex hormone in the male is testosterone, that it is in more abundance in the male, but you also have testosterone and other androgens in the female. And so from the endocrine point of view, I would like to suggest you to, now start thinking about these hormones being in balance. The important thing is to understand that they needed to be in balance, either in the male or in the female. The only thing is, in the male, you have more testosterone and certain level of estradiol that is produced by all the tissues where you have aromatase. And then estradiol produced locally in this tissue will have action in this tissue, several tissues, including the central nervous system, but also the estradiol will be in the serum, circulated in the body, right? So this is something important. And then when you consider the females, it's also important to consider that they are also in balance. And this balance will direct actually the way, especially, the physiology of each tissue in health, or when it is under an inflammatory condition. The balance of these two hormones will dictate how the immune cells are going to be there, how these immune cells are going to behave. And that's an area that it is increasing now in terms of data and understanding, because, just in chapter 2, when you show that when you compare females and males, and you show differences in leukocyte numbers, and I think platelets are the ones to have more difference. And in terms of leukocytes, if you compare, if I'm not wrong, I don't know, I don't remember exactly what is the page where you have, oh, I see, page 29. What you show here in terms of platelets, you see, you have, in males, you have a significant change in platelets, but you don't have, well, you also have changes in platelets in the females in figure 2, when you are counting these cells. And when you go to figure 1, the top of that page, you see that you have a male and female difference in terms of leukocytes. But when you isolate these leukocytes and you think the type of receptors that they have androgen receptor and they have estrogen receptor, either in males and females. And when you consider the literature, isolating these cells, putting in different hormone concentrations, you can see that they can display different functional phenotypes depending on the ratio of these hormones. Yes. So I think in vitro, we have an idea that the balance of these hormones are important if you are considering a phenotype that it can be like more pro-inflammatory or maybe an anti-inflammatory phenotype. And that's where you also have your glucocorticoid receptor, because depending on the phenotype of these cells, I'm talking about, I don't understand too much about platelets, but I understand more about leukocytes. And depending on the phenotype, you can have a differential expression of AR, ER, and also GR, the one for glucocorticoids. And then the endpoint that, depending on the endpoint that you were measuring, if it is a cytokine expression or any other type of, readout that you have, they can change. And so that's the very interesting data that we have, because then you have this in vitro data that you needed to try to understand how they are going to behave when they are in your explant or when they are in vivo. And that's where I think it's very important that from now on, you don't forget that when you are considering the lungs of these patients or the lungs of your animals in this preclinical data here that you have, that you do have estradiol circulating in these animals because you are measuring the plasma estradiol levels, right? And they are circulating, but they are originated also from your lungs, because there is a literature showing that the lungs have expression of aromatase.
Yes.
Right?
Yes.
And so one thing I was thinking, Fernanda, that really it's very exciting to see here, because I think you have enough data, and probably depending on the focus that you will have now in your research, you have a very nice model here to show how much aromatase in males and females will dictate, the level of injury that you have once you are inducing the brain death, and you see this inflammatory condition that you have in the lung, depending on if it is male and female. So what would be the consequences of if you have more aromatase being expressed, in the lung that is under this injury, or less aromatase expression? Why I'm saying this? Because when you measure the serum level, is one thing. It's important. It is important to know how your animal is in terms of, circulating hormones. But we do know now that most of the time, the amounts that you have circulating does not represent what you have in the tissue. So how this is going to affect what you were proposing in terms of treatment for the patients, like for the previous professor, he was asking you, how you were trying to help, the recipient or the donor, the donor to have a better tissue or a tissue in a better condition for the recipient. So that in that area, you are treating pharmacologically your patient or your animal here in the preclinical model. So I know that what you are doing is to try to use the hormone, and this hormone is getting in the whole body, including the lung, and acting directly in their receptors. So I understand that there you have a pharmacological effect, and that you have enough data showing that maybe this is a way to go, in terms of, if you want to help from the clinical perspective. But what I want to show you here is that maybe by focusing on these basic ideas, basic events that are happening when you have in your preclinical model. So you are inducing brain death. So what is really happening inside these lungs? So I just remind me, maybe I don't know if I missed, but I don't remember to see any reference here in your work about the level of aromatase or the importance of aromatase for your paper. And why I'm saying this? Because there is some literature showing that with lung tumor, one thing that they see is that once you have the tumor cell in the lung, one thing that happens is the concentration of expression of aromatase reduces. So actually what you have is less production of estrogen, of estradiol in the lung, in the tissue. But you do change the expression of the receptor for estrogen. So it's a balance. So you are inhibiting the ability of testosterone to be converted to estradiol in the lung, but at the same time, the lung is having more expression of certain types of estrogen receptor. And they see that in this case, in tumor, if they use an aromatase inhibitor, they can reduce the growth of this tumor. So you see, an inhibitor of aromatase is actually helping this situation. It's a tumor condition. I know it's a different condition from your model.
But we see the regulation.
Exactly. And so I think one important thing that you have to work now during your reading is to include the concept that if you are considering estradiol, either in the women or in the males, this is coming because you do have testosterone converted by aromatase into this hormone, right? This is the first thing. The second thing is, according to your chapter 7, you state, well, I know that this is, you have ongoing experiments with your collaborator, your advisor, actually, Henry in Groningen, that you were trying combined treatment with estradiol and a synthetic glucocorticoid that I don't remember if you say. Oh, okay, yes, a synthetic glucocorticoid. And one thing I was wondering, you know, is, so when you have your, let's go to the clinic, to the clinical situation now. When you have your patients that are in brain death, so, and let's think either males or females, especially on the males. If you have males, older age, or maybe males that are in reproductive age, but they do have hypogonadism. So they have lower concentration of testosterone. What would be the impact of that in their lungs? You know? Okay. And on the other side, it's the same situation that you have with your females. Because when you tell me that you are over-ectomizing your rats because you do want to reduce the estradiol level so you can test your hypothesis that estradiol is an important instrument for tool for, you know, the purpose that you want here. Well, when you are doing that, you are basically mimicking the situation of a post-menopausal woman. The post-menopausal woman, she has, or your animals, they have lower estradiol concentration, circulating estradiol concentration, because you just basically don't have the ovaries there anymore, right? But what happens in these animals in terms of the other sex hormones? You do have increase in androgen levels, right? So you see, when you are thinking about your hypothesis, do not forget that when you are dealing either with the male or with the female, you do have differences in this very important sex hormone that is actually the molecule that is the substrate to produce the sex hormone that you are taking consideration for your hypothesis. Why I'm saying this? Because at the end, what you have, it's complex. I know it's not easy to dissect everything, of course, but you do need to take in consideration that in the lung, maybe we call, Fernanda, have you heard about intracrine regulation, regulação intracrina? Have you heard about that?
No, I don't believe I have.
Yeah, so regulação intracrina means the the steroid hormones that are actually produced in the cells, in the tissue, that is not in the main, like the gonads, like in the male and females, the sex hormones. Let's focus on
Yes,
this.
so probably in the lung.
The testes or adrenal gland, right? These are the two glands that we consider, right?
Yes.
But then they go to the circulation, they get into these other tissues, and if they find the cells with the right enzymes, they can be converted into these other products. In this case, androgens to estradiol, that is the case that you are studying here. So take in consideration that the lung is available to conduct intracrine synthesis of steroids. And with that, I think you can then have more opportunities to see exactly the protocols that you have to conduct to go to the studies that you want, that you also say here in your perspectives, is to understand, for example, the receptors that are involved in these estradiol effects that you see in the lung. So my question, well, not a question, but I would like your comment. So when you say the receptors that you are going to study, you did say before and in your thesis, ER beta is the one that is more present in the lungs. So it is more present in the lungs in normal condition, because this was not clear. So the lungs, the lungs have different cell types. Do you know if the different cell types would have different expression of ER beta and alpha, or it is like in general, the lung, all the cells are, more abundance of ER beta? Can you tell me a little bit more about that?
Sure. So specifically on the expression of estradiol receptors in the lung, so if we talk about what constitutes the lung specifically, I think that's what, when they do research on that, they see that they have more beta. From the papers that I read, it's usually a normal lung. It's not one that was actually had any sort of trauma or anything on them. But since the data is showing that the treatment with the agonist for beta actually protects it, it kind of all comes together. But if we take into account the vascular system, so like endothelial cells and the vessels, we actually know that is not beta, but actually alpha, which is the one that is more present. But the literature is not that much. We know that there are some papers, but most of the time they are actually studies done with gene expression in the lung tissue. And they just have like a homogenate of it, and they analyzed for gene expression. So we know that it could possibly be that, but probably further studies would need to be made so we can like make sure. Actually, in the continuation of my work, and as I said, we were trying to understand the receptors. And one thing that it didn't make to the final thesis, but we have data regarding the expression of estradiol receptors, not in the lung yet, but we did on the kidney tissue. That is the work from my other colleague that defended also not long ago. And what we saw in the expression of this receptor is that when we have like the sham group, so just the ventilation and not that much of harm to the lung, they have the expression of the receptors of beta, alpha, beta, and also the GPAR. But brain death actually makes them express more. So it was immunohistochemistry analysis. So we know for sure that we have a greater expression. And what we saw also from our treatments is that possibly the estradiol treatment in which we did the continuous infusion. So we just kept on giving more estradiol. Possibly it wouldn't be the best sort of treatment, because what we saw was that the estradiol in those great concentrations actually had a negative feedback. So it reduced the expression of these receptors. So possibly that could explain why we see difference between the 6 hours and the 3 hours treatment. But not going to the estradiol receptor, what you said about the aromatase and also the other receptors of the other hormones would probably contribute to understand it better, because we know that when we have already just lower concentrations of estradiol, we already have in the overrectomized females an inflammatory process going on. When we have the reduction of corticosterone, we also have inflammatory responses in the lung and also the system. So probably for the future, we would probably need to take into account all those components to really understand what is happening. And probably it's very complex, because in the brain death individual, not when we talk about the recipient, but in the brain death group, since we have the failure of the hypothalamus pituitary, the release and the control of these hormones is completely offset. So we will have the concentrations that are circulating in the system. We know from previous data that when we see like 3 hours after in the experimental setting, that we don't know exactly what happens in the clinical data. But if
but when we just
yes,
sorry to interrupt you, so because I think we are almost
yes,
our time, but I think you were mentioning something very important, and I'm glad you were sharing with us the data on the kidney. But I do say, Fernanda, just to start concluding the questions,
yes.
It would be very valid if you, because I think you still have samples, especially for the immunohistochemical studies, run in parallel, ER, AR, the androgen receptor, and the glucocorticoid receptor. If you do have these immunohistochemical studies, and at the same time run aromatase, there are antibodies against aromatase. If you run these 4 targets and you see, the lungs before and after your brain death, and then it would be very nice if you still have material from your estrogen treatments. So then you can learn a lot, and I think these would be pieces, very important pieces that could be answering lots of questions, in terms of the basic science behind, all these events that you have in brain. And remember that maybe this would be also a way for you to contribute more about, what are the factors or the elements involved in this endocrine regulation for estrogens, in the lungs. I think this would be very, very nice. So if you still have samples, or maybe, in the future when you are running another sets of experiments. So just as a final question, if I still have 2 more minutes, it's just a curiosity, because I think when you were proposing this co-treatment, estradiol and a synthetic corticosterone, glucocorticoid, I mean. So I would think, what would be the consequence of this synthetic glucocorticoid in the lung that is going to the recipient? So thinking now, if this would apply to the clinic. So do you think that this glucocorticoid basically in the tissue, because you would have the glucocorticoid, could actually have a better impact or help, the recipient that is receiving this lung, or do you have any information on that?
So my guess would be the it would probably help. And I couldn't probably, didn't really know how much of this that would be circulating in the perfusate would actually really go into the recipient. But from data that we have regarding either ex vivo lung perfusion as just one setting separated, but also when you look at the data that is the transplant actually happening, usually they do give sort of cortisol, and it has proven to be very good for treating inflammation. So my guess is that would probably help as just the whole.
Okay.
Yes.
Okay. I think I could continue to talk to you, with you about this, but I'm okay now, Fernanda. Thank you so much. They are just comments, and of course you and others on the team to consider. And we have some tools here. If you need, just be, you are welcome to come here and take antibodies and try on your studies. And so good luck from now on. And I think I would like to thank you for this opportunity. And I think I conclude my questions and comments. Thank you so much.
Thank you. I think it has brought many good questions.
Okay, then thank you, Professor Maria Cristina. Now we are going to move on and to take the considerations from Professor Paulo Cardoso, that's going to then make his questions to Fernanda. Thank you, Professor Paulo, to be here with us today.
It's an honor. Thank you very much. I'll keep on, going in the English version of this defense. I think it's fair to Dr. Erasmus and Dr. Levenink that they're here. But I was fortunate to meet them back a few years ago when you came to São Paulo. First of all, I'd like to thank you, Ana and Fernanda, for an outstanding piece of work. Ana is a very promising super researcher that we have, and we're very proud of it. And I am particularly proud of having someone in the, so experienced in our, university. It's wonderful. And Fernanda is a byproduct of this tooth science, which is very good as well. And I'd like to congratulate you, Fernanda, for an outstanding presentation. It really cleared up a lot of my little, glitches and questions. Like Dr. Erasmus, I'm a surgeon, so I have to be brief and precise. So I won't be too long. I have the, usually I make this this questioning in writing, so I sent you via email an English version and a Portuguese version, and but we go along. I just remember you that I took as a reference the PDF copy of the thesis you sent. So it's not the book. The book, I'm going to keep it. That was for my my boss, Professor Paulo Fernandes, that unfortunately was unable to participate today due to some urgent matters. So I was put in the field 4 days ago, and I had the pleasure of reading through this work over the last days. It was fantastic. I really enjoy it. Thank you so much. Okay, so for starter, I'd like to make some general comments of the study that it's well organized into 7 chapters comprising an introduction, 5 original published articles. 4 of them have been published and 1 is in preparation as far as I know. And a discussion on future perspectives, which is very good. It's exactly what we want to see as a future perspectives. The central theme of brain death is a very interesting thing, and the differences in inflammatory response between the sexes is common in the common denominator within these 5 papers presented here, and through the spectrum of consequences in complex experimental models. That hit me in the heart because I really dedicated many years of my life back in my master's and PhD and my training in Toronto, Erasmus mentioned Schaff. Schaff and I did our fellowship together, so we're still good friends, and Tom Waddell. So I've been, Toronto is part of my life ever since. And they are really outstanding in what they do and what they develop and so on. So when I came back to Brazil after training, I pursued my PhD thesis and then a research line on brain death, and then DCD donors, which was back in the 90s, something very unthinkable, and today is a reality. So transplantation has this wonderful thing of renovating itself, right? So so the text is wonderful, it's easy to read. I like the style, it's very homogeneous across all the papers, which is fantastic. I like it very much. And I'm not usually a fan of epigraphs. Actually, that's the page we just skip right away as examiners, but yours in scientific works, most of it. But the choice of the title of the copy in the Portuguese hit me directly, because the ingenious phrase, there's something here that doesn't make sense, let's go and poke it with a stick, is perfect. And it has in its meaning the author's genuine interest, your genuine interest in research, demonstrating the restlessness and perseverance that help her, to build this 5 excellent quality scientific contributions. Well, having said that, I'm an unconditional fan of science fiction literature since I was 9 years old, and I'm a researcher since forever. So I instantly caught the intention of the author and the phrase of this genius Scottish screenwriter, which is Stephen Moffat, who has been writing for the series Doctor Who since 2005. So he's just a personality. Moffat summarized irreverently and simply the real essence of scientific investigation. For those who don't know in the audience, not us, but Doctor Who is a British science fiction series produced by BBC for TV since 1963. So appearing on the Guinness World Records of the longest running science fiction television series of all time. So you got a good start. Very good. You caught me in the first page. Anyway, in the summary and abstract, you summarize the essence of the study based on the premise that and the fact that females have a better tolerance and attenuation of the magnitude of release of inflammatory mediators compared to males. The interest in this line of investigation in the local and systemic inflammatory process caused by brain death is well summarized in this section, highlighting its high relevance in the context of lung transplantation. The influence of female sex hormones and their decline after BD, which is brain death, by the way, reminds us of the biological truth in which the female sex was bestowed by nature with the task of preserving the species with a natural protection against some pathological processes, in particular the inflammation. So we all know that you're much better than we are, and this is true. Nature has made this this way, and I think it's wonderful to explore this, right? And you've done this pretty well, and it's a great line of investigation as far as I know. So this protection declines along with other vital functions after brain death, since it's recognized by the body as a precedent for clinical death. And so our whole organic economy shuts down step by step, slowly, when the clinical death is very close, right? So, and that's the problem, because that's where our donors come from, right? Most of them, except for the living related, which is, and this is something that I always like to investigate. So these protective effects of estradiol in female lungs after BD suggest treatment with estradiol as a therapeutic for donors in brain death and or during ex vivo pulmonary perfusion. So we'll go back to that in a minute. I have a couple of questions about that. So the general introduction is very good. It's brief, presents the problem in a concise and easy to understand manner. Nevertheless, the author offers the reader an extensive literature review with 87 references. That was wonderful. I'm writing my docencia right now, so you helped me a lot. You don't know, but that helped me a lot. You provided me with some new reference I didn't have, so that will help me. Thank you. The worst performance of lungs from female donors are well explained and characterized, providing a clear basis for the line investigation, being outlined on page 3 and in estradiol and pulmonary inflammation, item. From this point onwards, the text goes deeper into the topic of pulmonary inflammation, and the role estradiol follows. So here, you and your colleagues explain the role of estrogen receptors, which was new for me, their distribution between the organs and protein signaling mechanisms through non-genomic mechanisms and protein transcription. So next, you just go and discuss about preservation and EVLP. So on page 7, you don't have to go there because I'll ask you the question. I'll just transcribe that here. Line 4, end of the first paragraph, you describe clinical and experimental EVLP strategies that allow for up to 12 hours of ex vivo normothermic perfusion, and cites references from 2008 and 2009, which are the reference 63, 69, and 70, by the way. So my question is whether if the clinical use of this time, right, would be closer to 12 hours or less, because these are very, pretty old references in terms of EVLP, which has been running through like crazy over the last 5 years. So this is one thing. At the end of this item, you describe a method for removing leukocytes together with cytokines and suggest the possibility of future incorporation of both in EVLP, both males and females. So there's an important issue here, which is the current clinical focus of using EVLP for DCD donors, right? And so in these, EVLP is reserved for reconditioning lungs. And Dr. Erasmus was very accurate in this. So he made a very interesting point where EVLP, if you don't treat the lungs, you just put them on it won't help inflammation because it's a self-perpetuating mechanism. So this is a very good window of opportunity for you, because if you can use estradiol, for example, as a treatment, perhaps this would actually improve the whole thing. Let's see. And that's one of the messages I'd like you to convey. So in this, EVLP is reserved, therefore, for reconditioning the lungs with significant functional impairment, usually coming from borderline donors. So if you go to the first paper, right, they used intravital microscopy, which is wonderful. When I came back to São Paulo to join the the University of São Paulo team in 2009, I was impressed that a couple of years later, you're doing this very easily, and it's a very wonderful way of looking at the microcirculation. And it has limitations, but it's a wonderful way. It helps a lot, and you've done a lot of good. The lab has done a lot of stuff on that, which is very good and helped us as well. So you have an extensive experience in the reduction of microcirculatory perfusion in males with microthrombus formation and maintenance of perfusion in females, demonstrated not only the superior platelet count, but also reduced platelet count aggregation in females after brain death. So this is a very good indicator, and I think it's a good point, right? That should be emphasized all through the way. So if you go to chapter 3, the paper 2, right? Overectomy of the methodology. It is stated that ovariectomies of mice animals, receive paracetamol, right? Because you do paracetamol in the water, right? Use 530 micrograms per mil. In drinking water, add Libitum for 3 days, and brain death induced 1 week later, right? So it's about 10 days from the start of the operation to the end of it. to the end of the waiting time. Consider that oral acetaminophen, right, has a weak anti-inflammatory activity, right? And there, I left you with a small reference for that. It's absorbed in the small intestine, has high and variable bioavailability. I ask if the subsequent 7 days of washout of the drug would be enough to avoid any synergistic anti-inflammatory effects that by chance could interfere in the results. So could you answer me that first? Because if I go down, we end up forgetting the questions here. So there are two: the clinical use of EVLP, and if whether acetaminophen may perhaps change anything in this inflammatory response.
So first of all, I wanted to thank Professor Paulo Cardoso for your presence. I think it will contribute a lot to my thesis. And first, the last question, which is more fresh. So the acetaminophen in the ovrectomized females. So this is a technique, and the use of acetaminophen is very much used in other models. And these 10 days is exactly because we know that it could affect not only the surgery, but also the use of drugs to make the animals more comfortable after the surgery. So we use exactly those 10 days, so they could already be in a more homeostasis, so they could be in a normal condition, even though they had the surgery. And actually, acetaminophen, if I'm not wrong, it has around 10 hours of biodisponibility. So I do believe that when you have 10 days to actually process that, we wouldn't have any sort of remaining effects from this drug. So I do believe those two factors, literature and also what we know from the pharmacokinetics of this drug, it wouldn't possibly interfere with the brain death and everything. The clinical use of EVLP, I don't believe I remember exactly the question, but you were asking about the works that I have described in the introduction, correct? Because they were a bit more older than the really new literature that comes every day regarding EVLP. I couldn't say that I have read everything. I try to read a lot, but we know that there is every time new things coming and new treatments, new settings and everything. So I do believe that we, even the same work that I have already explained here, that has done the 12 hours of normothermic, I do believe that the same group has already published new works regarding this in the clinic, if I'm not correct. But I guess probably for this, for what I was writing here, even I couldn't say exactly, but either I just focus on those ones because they are more the basis and the start of what we know right now from the EVLP setup, or maybe I just completely skip it then. So, but I guess probably I just regarded those papers because they were the first ones that started showing really great possibilities for preservation of the organs. So this is probably the reason. I don't know if you wanted to ask anything else about the EVLP.
No, I'm fine. I'm fine with that. That was exactly what I wanted to do, and the reason why I picked up this acetaminophen thing as well is that recently I teamed up with Professor Maria Cylinder, which is a very good researcher, and she works with inflammation and inflammatory systemic cross-talk inflammatory markers. It's a wonderful line of research. And she taught me something very interesting that some analgesics and particularly non-steroidal, they can deposit in places and they can change, right? Several markers that we use like interleukins and stuff. And so that's why I became very aware of these things, and I no longer use them for as analgesics. I use something else in the animals because I know that that might be a change and it might be a criticism. The good thing is that you have already published this paper and I wasn't in the board, so that was good because I would have asked you for sure that. But anyway, so that was good. So let's move on. Chapter 4 on page 63, the results section. There's a figure 2, the difference in the histopathological quantification of pulmonary edema between the sham and the brain death group is slight. It's very small. It's about 3,200 and 3,048 units per millimeter square. The same occurring with leukocyte infiltrates with this 2,100 and 2,300. Very small difference. Therefore, I'd like to ask you, how could you be sure that there was really there was edema and significant leukocyte infiltration in the brain death group? Because this difference is so tiny. And this fact reappears in the discussion on page 68, so you say that. So I'm not saying that your findings are wrong, they're probably not, but the difference is very slight. So how would you explain that?
Yes. So the other data that we have exactly that would actually help us understand this difference would be the let me find figure 7. In this, I think I showed also in my presentation, is the data regarding Evans blue dye, also nitric oxide, and the respective enzymes that produce nitric oxide. This data also correlates to probably edema formation. It's not really something that directly influences that, but we could relate to the increase of permeability. So what we see in the figure 2, so lung histopathology analysis, it is that when we compare only for this kind of analysis, which is only looking at the lung tissue, and we actually actively count in frames of the lung for edema or hemorrhage formation, we don't see that much of a difference because, as I explained before, the sham group is a group that also goes under ventilation, and we know that that could, in the long term, actually harm the lung. So what I would say is that combining these data also with what we have regarding permeability would actually explain why we could really say that we have this edema formation.
Okay, I'm happy with that. That's good. Let's move on to the next one. Also on chapter 5, paper 4, the research focused on long-term anti-inflammatory effects of the estradiol in lungs, which is, I think it's the real cherry on the top. That's very interesting. So how long you can go with that. So among the analysis performed, the cytokine analysis through quantification in culture medium, previously described by your advisor, Professor Dr. Ana Falopa, and published in Shock in 2013, is ingenious and simple. So I have one simple question for you. So you minced that in small pieces, right? And you put it in the wells. Is that okay? Is that what you did? Because it's very summarized. I went back to the Shock publication years ago to read what Anna has published, and I understood that you just put them in there, right? You don't shred them, you don't mince them in very small pieces or homogenize, nothing like that, right? Yes. So it's chunks of lung.
Exactly. It would say. I can't really say exactly because we don't actually measure with a ruler, but it would be like 3, 4, like a very small piece, so 4 millimeters of the lung. So imagine like a cube of the lung. and we tried to cut it this small pieces so we could put it in the video. And afterwards, we need to still have this lung so we can actually weight it and know exactly how much was produced regarding the size of the tissue that we put in the medium. So we could correlate to the tissue, not only just like the production in general.
Okay, I understood now.
One
I
more
understood.
explanation about the technique.
Sure, sure. It's interesting because usually, for example, we do some research on tissue engineering, and when you homogenate tissue, you get a wider range of secretome, right? And which is, but it's probably not the same as what you did. But since you have this published before, validated, it's fine. I have nothing against it. I just wanted to know how small you were going in these things.
Oh, yes.
It's like it's like grandma's soup, right? It has to be chunky to be good. This one has to be tiny to be good.
Exactly.
Anyway, so chapter 6, paper 5, we're getting there, which is contained in the article still in preparation, whose intention was to evaluate the differences between sexes in animals with brain death submitted to ex vivo lung perfusion. The question is interesting. The findings confirm the presence of more inflammation in females after brain death, but EVLP alone was unable to reverse the post-BD pulmonary alterations, as well as in inflammatory and oxidative stress markers. I think you use myeloid peroxidase or something. So this is interesting. So my question here is very simple. So when you did that, did you figure out or did you hypothesize that you might be putting something into the EVLP and try to see what happened? Or the idea was just establish the model and see how it works?
Yeah, exactly. It was the second explanation. So the first thing is that this work, as you guessed it was done in Groningen with the setting that they have already there, and they already have works published with that setting in rats. So we used their expertise, and I had a lot of people helping me actually perform this work. So what we wanted to know is that in the different model that they use, which is the slow induction, we have the brain death also, but as it is a bit of a different model, and we know from previous work from Dr. Vilvanik that it could affect differently different organs. So if you have a fast induction, it could be worse to the lungs, and when you have a slow induction, it could be worse to other organs such as the kidney. So we wanted to first establish how it would actually work for the lung, and also at the same time really know the starting point question, which would be if males and females would actually have a different response to that. So it was to answer to those two questions first, and then later on we wanted to actually try and start to see the difference of treatments, either corticosteroid, which we already have literature showing that is good for males, but we don't know what happens with females, but also maybe do a diet treatment and see if in the EVLP setting could work as controlling the inflammation, which is already something that I talked about in the future perspective.
Good. I understood. That's pretty good. But that leaves,
Yes.
I'd like to leave here a suggestion for the future. So EVLP is very interesting in this context, and is something that you should pursue in the future. And because it's simple, it's not too complicated, and it's right on the top of the list today. So but to give you an example, when I was training in Toronto, we're doing temperature research on what's better, 4 degrees Celsius versus 10 10 degrees was always better for a very simple question. Erasmus is saying, yes, exactly, right? You remember that. And we did publish a lot of things in rabbits and rats and all kinds of animals and dogs, that we used to do dogs at that time instead of pigs. And it was very simple. When you have 10 degrees, you don't shut down the cell. It's still working. The mitochondria is working. Everybody's happy, but at a slower pace. It's like a friend of mine used to say, cells on vacation, right? So it's very much that. So today, 30 years later, that was 1992. We're talking about 2022, right? Next year. We just figured out that that was it. 10 degrees is much better. Toronto has just published the 5 patients with that and the pig, work on that and everything. And it just revived everything. So EVLP has a peak and that will stay there because they use EVLP to prolong that. And the idea is to transform a lung transplantation into an elective surgery. No longer long nights, right, Dr. Erasmus? I know, 20 something years in transplantation, many nights awake and so on. And so have a fresh team, you have better, resources at your disposal and so on. So go ahead with that because it's interesting. I'm finishing here. So on page 95, the statement about post-brain death donors being the only ones used besides lobar donors is somewhat outdated. About a decade after the first report of successful lung transplantation using post-cardiac arrest donors was in 1995 by Dr. Love. It's a very famous publication at the University of Wisconsin in the US. And the use of DCD for lung transplantation gained a lot of ground among transplant centers because it's a very interesting resource. The initial experience was reported in Canada by Dr. Marcelo Saipo, one of my colleagues in southern Brazil. And I put in there one of the references for you. The clinical experience with pulmonary transplantation with DCD has grown exponentially, with 360 transplants with DCD being reported by the same author in 2015. So Marcelo published in 2000, and today they have even more. They just doubled that. So it's happening, right? It's just happening. So it's a very good thing to do some research on. And your line of research is very interesting for that. So I believe that based on the description of the material used, the EVLP was carried out in Groningen, right? Am I right? Yeah, good. I guess that. My question is what type of EVLP equipment was used for rats? Because it seems it was an adaptation of the system used for animals, for pigs, according to your text. I know that you have to, for example, here for EVLP, we use the IL2, right? Harvard apparatus system is a big thing. And it works very well. So regarding the solution used for EVLP that you call homemade steam, my question is whether it has been used and published before by your group. So did you try to do that? I'll tell you why. We've tried to do I was one of the developers of Perfadex for transplantation with Schaff in the 80s, but that was his master's degree, and I was his first assistant. We did a lot of research in that, and today it's a very good. So we tried to reproduce that in Brazil, and it didn't work. Right, it didn't work. So we tried to reproduce Celsius, for example, here. It didn't work well as it is. So manufacturing is not like, as I told you, grandma's recipe. Just put everything together. My grandma used to make a chocolate cake. Nobody can beat it. And she went to the grave and took her recipe with her. So one of my friends, my brother actually, reproduced that. He analyze and put everything in writing, and it's never been as good as hers. So that's probably something with the manufacturing. So for chocolate cakes and EVLP, this distance is not that long. So it might be interesting to know how did you validate that? Because you didn't publish your paper, right? So be careful because you might be subjected to very severe inquiry about this, right?
Yes. So exactly the use of the what we call here the homemade scene, which is actually just a perfidex with more elements. It is something that was actually passed on to me. So it was already done in other studies from another student. And she's the one that teach me the technique and actually help me perform and start the experiments. And I'm not really sure, but I do believe that she has already a paper accepted or either in publication. I don't remember exactly, but she would probably be the one firstly publishing with the use of this form, because we just continue something that was already being performed in the Lebanese lab. So.
Okay, yeah, that's good. Yeah, be prepared, because when you submit that, you're going to get some questions on that.
Of course.
Okay, on table 2, page 101, the results do not agree with the statements in the text about PaO2 and PaCO2. Have to revise that, right? So it's page 101, table 2. So if you look at the text and the table, they don't match, right? There might be something with the, writing it. On page 102, I believe that the best option would be resistance assessment. Due to its better relationship with post-transplant pulmonary mechanical performance. So elastance and compliance, we do that because it's like, how can I say that? It's mechanics. So if you put that on a flex event or something, they spit out all these things. So you don't throw them away, just use them. But actually resistance is the thing to do. So I would like to tell you that so you can emphasize on that. And figure 5, quoted on the top of page 104 of your written thesis that I have the PDF with me, refers to figure 6, right? On page 105, which is the edema index and not the myeloperoxidase results. So just make sure that since this is the PDF I received, make sure that in here, it's okay, right? This is important. And at the end of the discussion on chapter 6, you and your colleagues suggest the possibility of developing strategies focused on the control and reversal of the effects of inflammation, but they do not specify which ones, right?
Oh, okay.
Which I think is good. It's good. So you can do that now. You can specify. So I ask you, what your suggestion would be for this type of strategy? So what would you do, right, actually?
Yes. So what we have understood from what we have, not only from the previous treatment that we already did, which is the continuous one in different time points after the brain death, but also what we know, as I said to Professor Maria Cristina, we know that a continuous estradiol treatment did actually reduce the expression of this estradiol. So that could probably affect how effective this treatment would be. So instead of doing a continuous treatment in the future, I do believe that treatment with acute doses, so a bolus, not just like giving it in a continuous manner to intravenous, for example, would be probably something that would bring more good results for not only in the EVOP setup, but also in the brain death patients. And that would probably give, how could I say, would be more close to what we see physiologically in females. So they don't actually have like a continuous production of estradiol when it is needed. You have a fluctuation actually of the release of this hormone. So if we do that, we possibly would actually have more of the acute actions of this estradiol and also prolong these effects.
Okay, good. I had something else to ask. Well, the last question is on chapter 7 on future perspectives, which I think it's a cherry on the top, actually. at the end of page 123, you propose based on the benefits of female sex hormones, the treatment of the donor with estradiol after brain death and during EVLP. So my question is how this treatment would be done in terms of technical aspect of substance administration and its timing. So Professor Avelar just gave us a lecture, full lecture on that, but I still didn't figure out how can you do that. So you get that as a substance, as a active principle or something, and just put it in. When would you do that? So I know that this is a research line, and Anna will pursue that thereafter. But I'd like to hear a little bit about that, just to try to materialize how you're going to do that.
Yes. So estradiol, it is a hormone, and it wouldn't actually be a soluble component if you give it intravenously. So for the experiments that we did, and possibly when we applied to the clinic, it would need to be associated with cyclodextrin, which is what we call a carrier, and it is a sugar molecule which would make it the hormone soluble, so we could give it intravenously. So I do believe that when we have, for instance, the patient in brain death, it wouldn't be possible to give the hormone in other sort of medium. So we would probably give intravenously, such as the other sort of drugs that we already give to this donor, because we do need to treat all the different imbalances that brain death will produce. So we would probably need to do that, or either that, or what we also do is we give estradiol subcutaneously, and that could actually release in a slower manner the estradiol into the circulation. But probably the first one that I told you about, the intravenous one, would be probably the best one, because we could control better what we give and how much we can see in the serum. But as Professor Maria Cristina Velar said, we actually need to know what happens in the lung. So we are usually focusing more on the serum values, but also we would probably need future studies to understand how it is actually produced in the lungs, because we do have the aromatase, and we could have the production in the lungs. But we also need to remember that the brain death is a special case, because we will have no longer the release of the hormones, because we will have the break of the whole axis to the hypothalamus pituitary ovarian. So it would all be off balance, and we need to take into account all that, because when we had all the consumption of not only corticosterone, testosterone, but also estradiol that will be circulating, they will be not released anymore at least through the gonads. But we could possibly have some other production in other organs, but we actually need studies to really know what happens in this instance.
Okay, excellent. So that really concludes my questions for you. And so I'd like to summarize just saying that the study is relevant, right? This bold design and a fine piece of original research and a line of investigation with international collaboration. Who could ask for anything more than that? So that's wonderful. And I'd like to congratulate you and your supervisors, right, for this magnificent study in an interesting current research line. And I think the program, our program here in Brazil, postgraduate program, for the opportunity of evaluating this experimental work. And I thank my professor, my colleague and boss, Dr. Paulo Fernandes, for not being able to be here, so I could be here and profit from all this knowledge. I learned a lot with that. So thank you very much. That was wonderful. I'm very impressed and very happy with your answers for everything. Thank you. Thank you, Anna. Thank you.
Okay, then The next step is going to be the absence of Fernanda. Fernanda has to leave the room, as we are going to be able to discuss the answers and evaluate her without her being here. So you have to wait outside until, yes, and I'm going to ask them to shut down the YouTube connection in order for us to have a private meeting without the transmission of the meeting. I don't know, Fernanda, do you know the number? I don't know if they are listening to us at the moment. Maybe we have to call them and ask them to switch off the YouTube transmission. We have to keep that in mind, or we are going to transmit everything we discuss for the people watching in the YouTube. So we have to be careful to switch that off.
Só privado.